Hey, good morning, everybody. Welcome to Project Echo. This is the fourth series in our current series of four Echo sessions. And get through my housekeeping stuff here, and we'll turn it over to Todd for his presentation today. Again, usual disclosure of relationships. No one here has any financial relationships to disclose. And then our usual funding statement. We're grant funded from the State Opioid Response Grant from SAMHSA by way of Nebraska DHHS. And then, of course, I think everyone's familiar with the usual process for CME certificates. There'll be an email going out after the training with a link to a quick evaluation survey. After you do that survey, you will get your certificate. Check your junk or spam folder. I still have a few people tell me every once in a while that my email's going there. And like I said, this is we do these in these Echo series in groups of 4. So we'll be off in December. We'll be back in January and February with another series of 4 sessions. So we do a separate registration for each series of 4 sessions. I'll make sure everyone that's registered for this one will get a notice about this upcoming series of trainings when we're ready to announce that, which will be in a week or 2. Start opening up registration for that, as long as sharing information about topics and trainings. While we're off, of course, consultations with our team of experts are available anytime. Best way to do that is just to contact me. I can put you in touch with one of our 6 great experts. And I will let our experts introduce themselves now. Let's see. Ed, do you want to go first?
Yeah, sure. Thanks, Will. Ed Kaiser here, nurse practitioner. I'm in Omaha, Nebraska. Have been helping treat patients with substance use disorder for a little over 5 years now.
Janet?
Yeah, Janet Bernard, family practice physician from North Platte. Started treating opiate addiction with Suboxone and those type of substances in 2008.
Gail?
Gail Keller from Falls City. I'm a nurse practitioner, and I've been treating patients with Suboxone in Southeast Nebraska.
Stephanie?
Hi, I'm Stephanie Bennington, psychiatrist in Omaha with a special interest in treating substance use disorders.
John, are you on right now? Maybe he's not. He may not be on right at the moment. John Massey's a pain physician. And Todd, I'll let you introduce yourself and take it away for us.
Good morning, everybody. So Todd Stull. I'm a psychiatrist. It's kind of been practicing for a long time. So I've been fortunate to do a range of things within psychiatry as well as addiction, and been involved in kind of running addiction programs through the spectrum from outpatient all the way to inpatient, as well as methadone programs and consultation services in hospitals and so on for people that are really sick that often have kind of liver problems and so on to addiction. So when I say addiction, I'm talking across the spectrum, not just opiates, but that's kind of the funding and the grant we have today. So the topic today is something that's been bubbling for a long period of time that now is getting more attention. I don't know that there'll be time for a case at the end. It depends, I guess, how quick I talk and how quick I go through the slides. But if there are things that come up at the end, let us know. The one thing that I really want to make sure that we have the opportunity to do from everybody that's attending today, and you can either get on screen and say it or put it in the chat, is let us know things that you may think are relevant for topics to cover. And so we kind of guess at some of this along the way. We want people to get credit in CME, and we want them to be useful. When we first started this Echo, and this is a long time ago now, the idea was to cover a range of topics that are practical, that are useful for clinicians that are seeing patients that have substance or use disorders or comorbid problems, whether it's pain or mental health or other medical problems that are often related. And many of the individuals that have substance use disorders through their natural progression, especially for that small group that's chronic and relapsing, will have comorbid medical problems, whether it's liver problems or pancreatitis or infectious disease or various ranges of things. So if we can cover some of the things to make your job and what you may see easier, let us know, because that's really what we want to be able to do. And so please don't be bashful in introducing something that you think might be helpful or relevant. All right, let's go ahead and see if we can get started here. Can you see my screen now? Will's that, can you read the screen?
Yeah, that looks good to me.
Okay, all right. So the topic today is ACEs, or adverse childhood experiences, and kind of their effects throughout the lifespan, if you will, in terms of manifestations, not just with substance problems, but I went a little broader because I think it's more applicable for other sorts of co-occurring and comorbid conditions that happen as a result of adverse childhood experiences. I'm hoping this is a practical talk. It's maybe not the hottest topic for everyone, but you will see this in kind of a general practice, and you may not quite conceptualize it this way, or you may have a good understanding as well. So nevertheless, let's dive in. So we're going to talk about what are ACEs. We're going to talk about how this kind of got really formalized and launched with Kaiser in California with the ACE study. Then we're going to talk about the effects of ACEs, adverse childhood experiences, throughout the spectrum. And then we're going to talk about some kind of basic treatment strategies to address individuals that have gone through an adverse childhood experience. When you think about the spectrum and the vulnerability times, often the exposure is early, meaning that the events that take place, and I say events because it's usually not a one-time kind of event, although it can be depending on the severity. Usually it's a repetitive kind of nature. It's the ongoing exposure that a child experiences, after they're born. There is that time when they're more susceptible or vulnerable, especially as their brain and nervous system are developing. And when I say nervous system, I'm talking about peripheral as well as central, and peripheral includes autonomic influence and the 4 components of the autonomic nervous system. And so then often, there's a disease onset and then the trajectory or course of things. And so if a child experiences things, the earlier in general, the intervention, or the earlier the treatment or identifying things, the better the chance is that there'll be a more favorable outcome. That's not 100% true, but that's kind of a general way of thinking about this. So early exposure leads to a progressive of things that are influenced by disease vulnerability or genetic kind of predisposition and so on. Remember that as a kind of basis or tentative, who develops a substance use disorder? Let's just take prototype alcohol as a substance problem. About 50% of individuals who develop alcohol use disorder have genetic influences. So there's still that environmental component. Now let's take a look at when conditions develop during childhood. So you get the disruptive kind of behavioral disorders up front, or conduct problems, oppositional defiant, ADHD in the early years. You can see the years down below. Anxiety disorders start to come in. And so when we talk about mental illness and we talk about substance use disorders, largely starting between the ages of kind of, I say adolescence being 12 to 25, you can see how this captures this. This is schizophrenia for males. Females is about 10 years later, 25 to 35 in general. And substance use problems, again, start around that, 12, 13, 14 period of time. And so if you think about a adolescent who's using alcohol before the age of 15, the chances of them developing a substance use disorder are at least 50% by the time they're an adult. And so early use has an effect on progression and so on. And if you look at the top of this screen, you can see, although it's maybe not real clear, but the darker the color, the greater the brain area that's developed. So brain develops from back to front. So as you think about progressive brain development, the areas that are around emotional control and limbic influence, if you will, or the emotional components of the brain develop before the brakes, meaning the prefrontal cortex and the various components of the prefrontal cortex. So you can often find emotionality in teenagers. We've all had it. It's all normal. There's a range that's acceptable within that is considered the normal range. And it's the higher cortical areas that come online later in terms of kind of the prefrontal cortex and so on. Over half of kids that are exposed in this world are exposed to some kind of aggressive or violent crime or abuse every year, and roughly a quarter of them will witness a traumatic event before the age of 4. So clearly there's events happening that are out there, and exposure to a child through repeated exposure, as I mentioned early on, has the greatest effects over time, because that develops or has influence on development socially, emotionally, and within the neurophysiology of the brain. We spend a lot of money on events that are related over time when you look at the ACEs and the costs. So let's talk about the ACE study a little bit. It's the largest study of its kind. It was very selective, so it wasn't a broad study. It did not look at an impoverished population or really at-risk population. It was out of California. It was in the San Diego area. 75% of the individuals were white, 75 had attended college, and the average age by the time they looked at this with an even split of men to women was 57 years old. So it was really kind of a population you think, okay, they're probably not going to go through adverse childhood experiences and so on. And this was an ongoing kind of collaborative between Kaiser and the CDC that was really looking at a range of things and looking at patients who had, initially they were thinking obesity and some other related problems, and then they started to look a little deeper at things like abuse and neglect and family dysfunction and so on. And so they developed this scoring system to look at components of abuse, whether it's physical, emotional, mental abuse, if you will. And sometimes those terms are used interchangeably. And then a neglect, physical neglect or emotional neglect, and then dysfunction within a family, in the family unit, whether it's substance dysfunction, related problems, or parental discord, or observation of violence within the family, and so on. And then they factored into this the components over time of how does poverty and racism and homelessness contribute. And what was found is that the most prevalent form of child maltreatment had to do with neglect, and substance was tied to that. And so neglecting a child and then physical abuse was probably the next highest from this study as you look at it. And if you look a little bit deeper into this kind of whole neglect, you find that often these parents or the people that were raising the kids were using substances, and so they were focused on their substance or impaired from their substance, and sexual abuse became kind of a part of that disinhibited kind of component of substance use as well. If you compare it to the or add to it, rather, not compare it, but to the Ontario Health Survey, they found that men who children who went through adverse childhood experiences were more likely to report physical abuse and a poor relationship with the parent. Women were more likely to report as children they suffered sexual abuse, and there was parental psychopathology and often marital conflict. And so there was a little bit of a distinction from the men and women, that reported in the Ontario study and what happened to them as children. So you're going to hear me mention Bessel van der Kolk. If you haven't read the book, and I'll have it at the very end of the presentation, I think it's worth reading. He has spent his kind of life work looking at how to treat people. He's a psychiatrist that's Dutch, that looking at how to treat people that have gone through adverse childhood experiences and what happens with them. And so what he's found over time is long after kind of the event has passed, the brain keeps sending these signals to the body to, there's no trust that's going on. You can't trust the situation. You've got to get out of there. And even though there's no longer maybe a threat or the abuse going on, the brain continues to function as if it is still taking place. And remember the mind-body connection. So there is that effect on our, in essence, this is a mind-body connection or psychosomatic or psychophysiology through that process. So when we think about a child going through troubling times, they activate the peripheral system, the autonomic system, change vagal tone, if you will, which has a neurohormonal effect that now starts to influence brain structure and brain development, so that they have a overactivated nervous system in general, not just the autonomic or part of the peripheral system, but it has now influence in the central nervous system. And within this influence, then the brain develops inadequate mechanisms to calm or cope or deal with things because it's in a hypervigilant state. Let's go to Bruce McEwen's kind of material on allosteric load, because this is a misunderstood concept. The idea of allostasis is maintaining stability through change, right? And trying to maintain a stable system. But and that was the initial tenet, as they looked at some of this is going beyond homeostasis and so on, but maintaining stability despite stress is the idea of allostasis. And it was thought, okay, we maintain stability. But what was found over the years in some of the studies is that the stability is really misleading, because there's other systems that are being compromised, that are overactivated, and some that are underactivated, that change the function of the body, in essence, which includes the brain. So the idea of allostasis isn't really as much what we thought initially, and I say we, the people that are doing the research, as maintaining stability. Yes, there is a component of that, but there's also a cost for it through the process. So early trauma and negative kind of experiences now can influence protein and amino acid expression, and therefore influence genetic expression and changing firing patterns within the nervous system. So remember that there's a whole connected part within the nervous system. Let me digress for a second. So there's more glial cells than there are neurons in the brain, right? And the glial cells have a number of functions, not only maintaining nutrition and architecture within the brain, but there's also the lymphatic system that's in the brain, that's the equivalent of the lymphatic system in the body, and the sweepers in the lymphatic system are the microglia. So they're a type of brain cell that cleans the brain out, in essence, and gets rid of debris if there is adequate sleep. Well, individuals that have adverse experiences often have disrupted sleep architecture, in addition to other problems. But as a result, then the brain doesn't get kind of cleaned out and the nourishment that it needs to grow and development. So there's influence from that aspect. There's influence from the expression of, or genetic expression and signaling within the genetic expression, if you will, and then influence with normal, brain development, all the way from kind of the emotional control areas to the thinking areas and things that related to decision making and impulsivity and so on. So somebody that has a influence from a childhood experience, you'll see executive function disrupted. Executive function is the ability to organize and sequence and plan and anticipate what's going on and make decisions and control our impulses and so on. When those areas of the brain aren't developed, then it often leads to problems for the individual. So you can see, and this is a little bit of a busy slide, look at the red, the amygdala, that's kind of our alert system, if you will. It signals anxiety, and it's related to shyness and anxiety and so on. That area can be overactivated, but it's not just there. There are downstream effects from the HPA axis. So you get hypothalamus and pituitary influence that will drive kind of changes in hormonal levels, and especially within the adrenal glands and so on. In the meantime, the circle that's blue with the line in front of it kind of shuts off or diminishes the development of that frontal part of the brain that we're talking about. So this is just a picture looking at kind of the effects of what's starting to happen at the bigger picture. And there is now evidence to say that not only there's neurobiological changes and physiological changes, but altering signaling processes and cortisol levels. And now the latest kind of wave of things is really looking at cytokine function, right? So there's a whole range of cytokines that have to do with kind of inflammation or anti-inflammation, right? If they're activated through things like exercise or diet or maintaining kind of normal metabolic parameters within our body and so on, that can be anti-inflammatory versus those things that are pro-inflammatory. Let's go down that path a little bit for a second so I can explain it in a little more detail. So if somebody has gone through an adverse childhood experience and their sleep is disrupted, right? Now there is higher likelihood that their cortisol is going to run higher and their blood sugars are going to run higher. And now there's cellular inflammation. If there is cellular inflammation in this process, the membrane of the cells thicken. It takes more energy to get nutrients in and more energy to get toxic waste out. And some are trapped within the cell. Now you're choking off the cell a little bit, you get cellular dysfunction. So there's this whole cascade of events that can take place as a result of adverse childhood experiences. Now, it's not just, and this is not just in adolescence or childhood, can happen as adults, and that's really when it manifests. And it's not just those kinds of things that create problems. What do we know about looking at brain scans of kids that have gone through repetitive kind of difficult experiences? You'll see there's differences in ventricle size and brain size and overall brain development. This is 3-year-old kids who have gone through adverse childhood experiences that have been studied. So you get the idea that, hey, there is some changes in brain size and function and development, and the ACE experiences now start to have early impact on ability to form relationships, to express emotions, to communicate, to put words to emotions, to interact with other kids. And often there's a modeling process that takes place, whether it's modeling of neglect or physical abuse or violence or withdrawal. And this disordered environment then creates dysfunctional skills. And so these kids that are developing now see the world as judgmental and humiliating, and that they don't fit in, and there's an external locus of control as opposed to being self-soothing or internal kind of locus, and people are not trustworthy and they have to defend themselves above all kinds of things to survive. And so, this environment where kids are growing up now is really skewed for them because they are often scared and ashamed and humiliated and feel like that they're flawed along the way. And so if we look at the ACE and the number of ACEs, right, the number of risk factors, if you will, as they go up, you'll see impairment. And this is in the first 3 years, incidentally. You'll see greater impairment in developmental delays, not only cognitive processes, but emotional control and ability to form relationships. You'll see often detriments, although not as researched and notable yet as much as in motor skills as well. And so it's certainly a global effect, but most notably, we're looking at cognitive abilities and social interactions and communication and emotional control that are particularly affected from adverse childhood experiences. So let's break it down a little bit differently. A child who has 3 or more ACEs is 4 times more likely to have developmental delays, right? And I'll give you some further details down the road here with ACEs in terms of the scale. Children that have 4 or more are 30 times more likely to have behavioral problems in school. So now you've got challenges with them in school for the other kids that are around them, and for the teachers in the classroom, and so on. So it can be particularly challenging. And those things progress over time into adolescence. And now adolescents often will have trouble with authority, or they're cruel to their peers, or they have trouble forming friendships. And this just kind of progresses over time into other impairments that now start to emerge in the work environment, or further education, or what an individual chooses to do with their kind of spare time or social activities. Often broken families and relationships within families, and repeated kind of divorces and financial problems and so on start to emerge. So you think, if we put this kind of in another picture here, if you will, adverse childhood experience, now there's effects on cognitive and social and emotional kinds of problems. The next thing that often emerges, especially during that adolescent time frame, 12 to 25, right, is adoption of unhealthy behaviors or risky behaviors. They're impulsive. There is low avoidance for harm, and high, engagement in high risk taking sorts of behaviors or processes. Now you start to develop other sorts of problems, the emergence of disease. There's physical problems, there's psychopathology in these individuals that have gone through and experienced repeated ACE experiences will die earlier than other individuals. So the whoops, I'm sorry, I went the wrong way. The next thing in a big picture here is to look at, there's this developmental time where there's a susceptibility and genetic influence clear over on the left, to where there's brain influence with neurocircuitry, neurochemical circuitry, cellular function, cellular mass, and so on, that now results in individuals engaging in risky behavior. And there starts to be formation of connections within various parts of the brain or circuits. So sometimes we refer to these as connectomes, and one of them is that gets a lot of attention, is called the default mode network. This is kind of the brain activity in a default, a resting state, if you will. And this resting state now is developed differently within the brain of a child and an adolescent that's developed, their brain is developing to where their brain is actually different. Now they start to develop other problems within work, or substance use, or having problems with crime. Mixed with this then is things like poverty and so on. So adverse childhood experiences are common, and they have their effect not only early on and in adolescence, but downstream, even 50 years later from the studies. So we can look at physical problems, which we'll get into. We can look at social dysfunction and mental health problems or psychiatric illness, and you can see that ACEs are a major kind of influence and determinant on the outcomes of those sorts of things. Now let's take a look at this slide here, because I think this is kind of interesting. On the left is someone who has not gone or experienced any adverse childhood experiences. And one in 16 of those individuals will be smokers. And if you start to move to the right, someone who's had 3 ACEs or 7 ACEs, you'll see the number of smokers goes from 1 in 16 to 1 in 9 to 1 in 6. Well, if you follow that progression with 0, 3, and 7 adverse childhood experiences with alcohol or IV drug use or heart problems or suicide attempt, look at the change in the numbers. So you go from 1 in 69 with alcohol to 1 in 9 to 1 in 6, or IV drug use goes up considerably. Heart disease goes up, from 1 in 14 individuals to all the way to 1 in 6 for the 7+ adverse childhood experiences. And suicide attempts go up dramatically, right? 1 in almost 100 now to for someone who's had 3 adverse childhood experiences, the attempts go to 1 in 10 and 1 in 5 for those that have had 7 or more. So there's a huge difference when you start to look at the number of ACEs that someone has gone through and their effects over time. And this shows you who's more likely to develop lung disease with ACEs. Those that have more kind of adverse experiences are much more likely to develop lung problems, largely due to smoking, but also exposure to other environmental toxins as well, or comorbid or co-occurring problems. So heart disease, cancer, so on, diabetes all go up as a result of increased numbers of adverse experiences. This is a really busy slide, so let me walk you through it. And I'm going to go through each of the areas just very briefly, but the take-home point from this slide, and it just gives you examples of what happens with adverse childhood experiences. The more ACEs, the greater the likelihood of developing asthma, alcoholism, depression, smoking at an early age or smoking throughout the lifestyle or lifespan, excuse me, more likely to develop heart problems, suicide you just heard me talk about, more likely to have job turnover and poor work performance, much more likely to engage in early sexual activity and get pregnant, and much more likely to be involved in domestic violence. So you can see ACEs have an effect on medical problems or physical problems, if you will, by our biology, as well as our mental health and social influence, work environment, domestic issues, and so on. So many individuals that have gone through adverse childhood experiences see themselves as defective or flawed or unlovable or incompetent. And as a result of the ACEs and this kind of built-in nature to the nervous system of hypervigilance and then thoughts that go with that, incompetent, I'm flawed, and so on, makes an individual susceptible to developing things like post-traumatic stress disorder. Post-traumatic stress disorder is kind of unique, years ago, battle fatigue and thought of in kind of the military, but it's very common for individuals that have gone through abuse or traumatic emotional experiences that they felt like their life was in jeopardy or serious harm. And now they continue to have this overactivated nervous system that generates signals that it's hard to trust the environment, it's hard to sleep, they're jumpy, they avoid situations or places that may trigger those kinds of things. And so it has a huge effect on physiology, and tied to PTSD often, or anxiety or panic and depression. So when we think about the impact of trauma and adverse childhood experiences on mental health, these are the common things that develop. So mood disorders, especially depression, substance problems, and especially those things that are slow or have a calming effect. So it could be opiates, could be tranquilizers, could be alcohol. Anxiety problems often happen, and including panic. And these individuals are activated easily. Often you'll find in this group that their anxiety, they have a baseline high level of kind of uneasiness and tension. And if you tip the scale with that, they get paranoid, because the hypervigilance and the activation of the nervous system really turns on strong. So they feel like something's bad's going to happen to them, because it has in the past. And that nervous system keeps the memory of that, even though it's not going. You heard me talk about suicide already. One of the underappreciated things, and this is especially, I think, relevant for primary care, for family practice and internal medicine and pediatrics, many times when we have physical symptoms, they're manifestations of emotions, right? So people may say, oh, emotionally, I'm doing fine, because it's maybe out of their conscious awareness, they may be pushing it down, but their emotions are manifesting as physical symptoms, right? So could be, I'm having back pain, I'm having headaches, I'm having indigestion, a range of things. And so remember, physical symptoms often are connected to our emotional states, and they represent the emotional tone of our body. It's not uncommon for people also to have or develop eating disorders, especially during that adolescent time frame, right? And so don't overlook the effects of eating disorders, and eating disorders can have especially anorexia can have very detrimental outcomes if not addressed. And you know, the idea of and I believe that it's probably, if not the most overlooked, it's certainly very common. Individuals that have adverse childhood experiences, their personality doesn't develop. So personality is that aspect of ourselves that helps us to deal with others. So interpersonal kinds of things. It has to do with how we perceive the world and see the world. And our personality has to do with how we regulate our emotions and our impulses and so on. And so when there is a adverse childhood experience, our ability to manage or cope with the world goes down. Happens with all of us, right? In the sense that the more stress someone experiences, the more regressive we become, more maladaptive we become. Some people have a very high threshold to manage that, but as the volume of stress or tension increases, we start to shut off the ability to think as clearly, to concentrate as clearly, to make as good decisions. And so we become less adaptive, if you will. And for individuals that have really gone through a lot of adverse childhood experiences, they don't develop the nature of the ability to cope or manage the world. So, you know, in a potentially self-indulgent world, they don't become self-reliant, if you will. And that's not uncommon. So I have borderline personality down here. It's certainly not the only one that can develop during this time. Borderline is between, you know, the idea of kind of being between neurosis and psychosis, but it's individuals that often have ups and downs with their emotions. It can look like bipolar disorder. It's clearly different, but it can look like it. And these individuals often feel, you know, empty and lonely and abandoned, and they have trouble regulating their impulses, and they have troubles with maintaining and relationships and so on. So, and this group under stress can get paranoid or look psychotic, right? And so that fits right into this whole aspect of adverse childhood experiences and someone developing potentially borderline personality. You've already heard me talk about PTSD, and PTSD often, you know, there's a lot of other things that go along with it. So when you think of the big picture, half of the people that have a substance use disorder in general or close to it will have a mental illness, and about 30 to 40% that have a mental illness will develop a substance use disorder. When you put ACEs with that, those numbers even go higher, if you will, depending on the number of ACEs. Now, how about physical problems? Well, I've mentioned this a little bit. So not only chronic problems like asthma and hypertension, but headaches, chronic pain. Remember, our emotional centers of our brain are you know, intertwined or connected and largely influenced by emotion and pain. Often go together is kind of what I'm saying, and it's often difficult to separate the two. And you remember our GI tract is kind of our second brain, right? So the nervous system and the GI tract both develop from the same tissue embryologically, neuroectoderm. And so when someone guts are knots, often their brains are knots, if you will. And so GI problems are very common, whether it's upset stomach or belly pain or nausea, vomiting, diarrhea, those sorts of things. And so trauma has an impact on a number of variables, including musculoskeletal kinds of problems. So, you know, here's another interesting thing that's overlooked, and this is a science that's really emerging in the last probably 20 years, and that's the influence of sarcomere on endocrine function. So sarcomeres within the skeletal muscle, there are substances that are cytokines produced called myokines. Myokines have an effect on autocrine and paracrine and endocrine function, and largely then can have an effect on hormones and hormonal balance that we often don't think about. Well, when the musculoskeletal system is affected, then it can have effects that carry or influence other parts of the body. So sometimes we forget the close interactions and the various components of how our body really is deeply connected and intertwined. And then, you know, the autoimmune disorders are higher in individuals that have gone through adverse childhood experiences. So tougher regulating oneself, tougher progressing with jobs, more likely to disconnect or dissociate or be detached. Some of these individuals will even describe kind of things around them not feeling real, or they don't feel real because they get into a disconnected state, if you will. And it's often a state where they're on guard and they're just below the threshold of the sirens going off, or the sirens are going off kind of in a low volume. And so they're very hyper vigilant towards any triggers. So we know that effects of adverse experiences don't have to last a lifetime, but what can we do, right? What are the stages? And we're going to get into just kind of some brief things here in the next probably 5 to 10 minutes, and then wrap up about what can be done. Part of it is really having an awareness that, hey, some of the patients I'm seeing, and maybe even more than I realize, that are having some of these medical problems, psychiatric problems, substance problems, it may be influenced by memory in the nervous system and adverse experiences over time. And so you have to kind of be thinking about that and have it in the back of your mind, and then maybe consider some strategies to either screen or talk about, if it's early on, talk about ways to help the parents and or primary caregivers to maybe navigate some of the challenges that they're experiencing and reach out and seek services, and then advocate for childhood intervention over time, right? This is a busy slide, go right to the middle of it. We want to develop a healthy, kind of resilient child. In the blue area, okay, in the blue, what are the factors that can be very helpful? Largely influenced by the environment where kids are raised. So children develop within the environment of relationships that begins with the family, if you will, and the family unit, the family structure being fairly solid, which includes parents being able to manage their emotions and avoid kind of dealing with or using substances, and having a nurturing environment, and parents that have a sense of value, whether that's through work or their roles, really important. And then we can build things in the community around that, not only within the school system, but early intervention kind of problems, making sure people have affordable housing and feel connected to the community, because there are various kind of touch points in the red with the red arrows that can penetrate, that if these things break down, that are supportive structures that help with the foundational ingredients of developing a healthy child, then if there's not enough of the healthy stuff in place, other things will start to develop. That's what we've been talking about the whole time, kind of covered that slide. So here's the ACEs, right? This is one scale. And you'll have access to the presentation through the website, but here's one scale to think about, and a scoring system to really look at. There are others that are out there, but this is a 0 or 1 kind of scoring system, and looking at the number of ACEs that someone goes through. The screens in our world, and I say our world, the mental health or addiction world, are the equivalent of the vital signs. You've heard me say that before. And there's not an expectation that necessarily, depending on the practice you're at, that everybody has a screen for a substance problem or a mental illness or an adverse childhood experience. But you may find that there is some utility, especially if you feel like things in the treatment aren't going the way you want to. You may need to step back and say, maybe we should implement a screen here to see what, where this individual is at. Some physicians or practitioners want to use the screens right off the bat. That's great, with whether it's substance use or depression or anxiety or ACEs. There's certainly nothing wrong with that. And it gives you an idea of, if someone's honest, it gives you an idea of a starting point. So if blood pressure is up, you're going to address that a certain way. Well, if somebody has a higher score from an ACE screen, or an PAGE questionnaire or audit for alcohol or whatever, you are going to be more likely to address that. The other part that's, I think, particularly important is approaching the patient, right? Thinking about how to have kind of a conversation. So instead of approaching the patient, with what's wrong with you, this assumes they're flawed, there's an illness that's going on, and it really sets the tone for more of a reactive environment and a kind of one and done treatment mentality. And that's not what we really want. So that's a take home point here, is that it's more about, hey, this individual has gone through adverse childhood experiences. And so let's learn about what happened to them. And they have deficits in their ability to manage themselves or cope with the world, or they have deficits in their skill sets that can help them manage their life. And so we need to think about, how can we approach this individual to set up the environment, the treatment environment, where they can kind of not only heal, but manage themselves, cope with the world better, and develop some skills where they can bounce back, bounce around, or bounce through. In other words, resiliency in the process, to where they feel more self-sufficient. And in that process, remember I said that the nervous system keeps the tone of these experiences, but that volume will die. It may not ever go away, but it will die down some if somebody develops more skill. So we want to think of a top-down approach, a bottom-up approach, and then maybe other strategies with medication. And so the top-down is the idea of connecting and processing the trauma, and that's the cognitive aspect. That the medication, as you know, maybe turns the volume down, and then the bottom-up approach is the starting point, in my opinion, and that's the turning down the signal of the afferent input from the autonomic nervous system coming up. So this is just a pictorial of kind of looking at kind of that mind-body kind of and spirit approach, and considering relationships. I don't want to get too caught up in this, but I want you to think biopsychosocial or holistic, if you will. And so there's a not only, let's say the body, there's not only eating right and working on sleep, which has a big effect on this, but the components of movement and exercise and what have you. So the bottom up, when you think about that, how do we affect bottom up? Easiest way, if you're in a primary care practice, is teach tugging on 10. So stretching out the vagus nerve through diaphragmatic breathing, slowing the world down, slowing that signal, that afferent signal coming up to the rostral part of the brain into the limbic area, so that there's more of a calming state, so someone can get into using the cognitive processes from the top down. You can do this through biofeedback or neurofeedback. Movement also has an effect on this, but I mentioned breathing. PMR is progressive muscle relaxation. So the idea is we want to affect vagal tone, right? And vagal tone isn't the sole answer, but it has a big effect. And probably the quickest and most effective way is to do breathing, eyes open, eyes closed, a minute in the morning, a minute at night, practicing and just focusing on your breath for longer exhalation, but low and slow, smooth and easy in terms of the breathing. So low and slow, smooth and easy. People get caught up in, should it be in through my mouth or in through my nose and out through my mouth? The biggest thing is diaphragmatic breathing. So you're tugging on 10, you're stretching that vagus nerve out, because that's going to turn the volume of the signal coming up to the limbic areas of the brain down. And when that signal gets turned down, then to cognitively process that, you're not trying to row upstream against a body that's overactivated, but one that's more calmed down, and it's easier to implement cognitive processes when the body is less active. So the top-down piece now becomes an awareness and a mindfulness kind of thing. And there's different kinds of therapies, mindfulness-based stress reduction and cognitive behavioral therapy. And believe it or not, that many of the CBT kind of things, cognitive behavioral therapy, yes, they're implemented by therapists, psychologists, psychiatrists, but as a family physician, you can learn the basic ingredients. They don't take very long, and they're easy to implement. And I don't have time to go into that today, but they're practical, they're solution focused, and they're homework kind of for the patient to do for them to work on some of the strategies that are part of CBT. Now, obviously, top-down includes family situation. Remember, psychiatric illness and substance use problems are family problems often, so including the family within this process. But there are other ways that can be used from the top down that it may involve seeing a mental health therapist or psychologist or psychiatrist that can be implemented as well. The idea is to develop, turning the volume down from the bottom up approach and develop a secure sense of self and trusting relationships over time, and setting the patient up to do that, not giving up on this process. So, mindfulness is really the idea, and I put 3 different things here, but really in my mind, mindfulness is the awareness of managing your attention, because your energy goes where your attention goes. And so helping the individual to focus on things that are helpful. I say, go to your garden spot where good thoughts grow, to manage your attention and energy on things that can be helpful. So it's directed attention through a process to help you to get to where you want to go. And it can be very useful. I wish I had more time to describe it. I don't, but I think you get the overall idea. Now, what about other strategies? There's the SSRIs, there's SNRIs, medication I'm talking about. There's other heterocyclic or atypical antidepressants. Some people would delve into the serotonin dopamine antagonists, like, things like Abilify and so on. Or there's medication, to turn down the signal, the autonomic system, whether it's prazosin, for nightmares and autonomic arousal, or clonidine, or beta blocker propranolol, which is lipophilic, gets into the CNS. Benzos probably don't have a place in this arena. I mean, there's always exceptions, so I never want to say never, because there's some people that they will be effective, but in most cases, they probably don't have an effect or a place. And then there's the other aspect of some of the emerging kinds of things with psychedelics, whether it's ecstasy, MDMA, or mushrooms in microdosing kinds of effects. And so more to come on those stories. This talk isn't so much about that. Take home point, though, and this is really kind of the last slide here. The take home point for individuals that regarding medication that have had adverse childhood experiences between the ages of 4 and 7, okay, that are fairly significant, antidepressants don't work very well for them. And so you've got to think about other strategies that may be effective. There's exceptions to that, but in general, the antidepressants are not overly effective, especially as the number of adverse experiences go up. The effects of and I say antidepressants, I'm talking really about the SSRIs and SNRIs for depression and anxiety. They're not overly effective as the number of adverse experiences have gone up from the studies that were kids of between the ages of 4 and 7. So here's Bessel's book, if you're interested. The Body Keeps the Score. It's a very interesting read. I would encourage you to think about reading it, and I will stop there. I appreciate your attention today. And I know we didn't have time for cases, so accept my apologies for that. I just didn't feel like there'd be time to try to cover some of the issues that I went through.
Thank you, Todd. That was very, very interesting. It feels kind of daunting, doesn't it, when you think of all of the people we've probably seen as patients in our lives who are suffering from all of that, and really kind of knowing where to start is daunting.
There seems to be a lot of people that we've overlooked that have in all walks of life that have really struggled. Kind of reminds me of when I used to work at the methadone clinic, and before I really knew kind of who was going to be coming in there, I thought, oh, most of these people are going to be homeless, lower socioeconomic, and all of a sudden it was like, wow, we got teachers and lawyers and bankers and all kinds of other people coming into the clinic here that are, you know, on methadone or need, you know, having trouble with opiates and need to be. So same kind of concept here. Looks like Dr. Massey's trying to increase the number of people that are here today. He's on twice, so I really appreciate that, John.
Yeah, that's some folks in my office who they like to use my Zoom. They want to be anonymous, apparently.
So if there's not any other kind of comments or questions, and it looks like there's some in the chat here, I had asked for input on kind of follow-up topics and direction for us to go. One of the comments is, or questions is, you know, how do you understand the causation versus correlation issue involving the relationship between ACEs and health consequences later in life? Good question. Is there a direct causation versus more of a correlation? I think it's in that middle stage where people start to engage in risky behavior and patterns of things that emerge with whether it's smoking, sex, drinking, drugs, and then those things carrying over into other aspects. The other thing we know about people in general, not everyone, but people that have ACEs are less likely to be physically active and they're more likely to have disrupted sleep patterns, right? So those things have effects on development of disease or medical problems and progression. So true of borderline personality. This is a blueprint for development of this disorder. Yep. Mindfulness clearly could fall into, yes, both the bottom up and top down approach. I completely agree. I included it in one, but clearly it can be in the bottom up aspect as well. CBT working in a CD center easily can use it, can make available. Yeah. So CBT, and Joyce brought that up. That'd be great if you'd be willing to share. Or, you know, we could have another kind of talk in that area. Any thought on how to prevent ACEs? I think it starts with, this is a big issue, right? And it's, and please don't be offended by my comments because it's not meant to be that way, but it was the notion of, we're going to work towards no suicide. Never in the history of mankind has there never not been suicides. So I think that's kind of a fantasy. I think we can do things to manage or reduce suicide and the risk, but I think it's pretty challenging to say that we're never going to have suicides. Maybe a long time from now, but it's gone on a long period of time. Well, the same is true of ACEs. However, the things that can be done, I think, are early interventions. I think things within the school system can be effective, early education. I think it's really, and I don't mean to dump this on the schools, but that's a point where a lot of kids have involvement. And I think one of the ways we can really start to conceptualize this is looking at what are the key ingredients for healthy development. And how many people use calculus now, right? Versus how many people are really struggling with getting a divorce or maintaining a job or getting along with a boss, right? It kind of seems like calculus becomes less important. And I'm not trying to knock math, but what are we really focused on in the education that can help kids develop, right? I mean, I'm a believer that physical activity needs to happen twice a day from kindergarten through 12th grade. And boy, there's not a lot of people that probably would buy into that. But at the same time, healthy physical activity and developing those patterns can influence the development of a lot of other things down the road and so on. So I think we need to really look at the educational kind of system and influence from that aspect. And that's one way, right? Programs within the community, right? Certainly community organizations and churches and religions. I think it needs to be built within a community, and then there's screens that can be done. And I think part of what this integrated health program that the Nebraska Medical Association is working on to bring mental health providers into primary care clinics. There's another place where you can have touch points or interventions within clinics to help parenting or manage situations or address parents that are having troubles or struggling in terms of not knowing how to parent. So I think it's a cultural shift and a systemic shift that's a big lift, if you will. So a lot to go with that. Yeah, Janet's comments, I could have just said that, right? Beefing up kid programs. So how about other topics that people are interested in? Anyone? I know we're at the end here and I apologize for going over.
We've also collected some of those in the evaluation survey, so you guys can put those there as well. But yeah, feel free. We can stick around for a couple minutes if you want to drop some ideas into the chat. You're more than welcome to do that. I did, and you can also email us. I received a good email from Kelly with some ideas. I'll share that with the team today. Thanks, Neil. And for those of you that need to hop off, just keep an eye out for an email from me later today with the link to the evaluation survey, and also information about our next series. We'll be sending that out in a week or two. That next series will be at the end of January, February. Yeah, we can stick around for a few minutes here if people want to throw in some ideas in the chat. We appreciate it.